Hey everyone, my name is Amy Fontenot and I did my master's project on acute pyelonephritis. A little bit of background on acute pyelonephritis. Pyelonephritis refers to a bacterial invasion of the renal parenchyma. Normally, pyelonephritis results from an ascending bacterial infection of the bladder. Approximately 15 to 17 women per 10,000 and 3 to 4 men out of every 10,000 will experience pyelonephritis yearly. Acute pyelonephritis, if left untreated, can lead to septic shock or multi-system organ failure and even death. If sepsis occurs, mortality rate is around 16%. Risk factors for acute pyelonephritis include regular sexual intercourse, use of barrier protection, spermicide use, diabetes, or recent urinary tract infections. E. coli is the most common microbe associated with acute pyelonephritis. Klebsiella is also known to cause acute pyelonephritis. In young girls, Klebsiella and Proteus species are typically more common. In young boys, E. coli and Proteus species are more common. In the elderly, E. coli is still the most common. Patients with acute pyelonephritis will often present with fever, costovertebral angle tenderness, and accompanying gastrointestinal symptoms such as nausea, vomiting, and diarrhea. It is not uncommon for patients to complain of suprapubic tenderness. Symptoms of acute pyelonephritis may also include dysuria, urinary frequency, hematuria, chills, and even fatigue. Children under the age of 2 commonly present with fever, emesis, failure to thrive, and trouble feeding. The elderly population is well known for presenting with fever and altered mental status. Physical exam and diagnostic studies are used to aid in the diagnosis of acute pyelonephritis. Specifically, patients with acute pyelonephritis will often be febrile. Tachycardia is not an uncommon finding, depending on possible dehydration or bacteremia. Blood pressure is usually within normal limits, but it is important to assess because patients can present with septic shock. General appearance is also another important physical exam finding. Patients often are generally well developed and in no acute distress, but patients with acute pyelonephritis may appear in pain or appear toxic. The most useful diagnostic studies used to aid in the diagnosis of acute pyelonephritis are urinalysis and cultures. Pyelonephritis is clinically diagnosed if the patient presents with any of the symptoms listed and if the urinalysis is positive for leukocyte esterase and nitrates. The gold standard for the diagnosis of a UTI is bladder bacteriuria via a Foley catheter or suprapubic catheter, but it's often not done due to difficulty. Often after a urinalysis is obtained, urine cultures are sent off to confirm the correct pathogen and the correct antimicrobial therapy. It is recommended that patients who are admitted for acute pyelonephritis should also have blood cultures obtained, since bacteremia is not an uncommon finding. Acute pyelonephritis should always be treated. Outpatient management is acceptable for patients with mild to moderate illness who can be stabilized with rehydration and antibiotics in an outpatient facility and discharged home on oral antibiotics under close supervision. Admission is warranted if the patient appears very ill with a high fever, is severely dehydrated, pregnant, has many other comorbid conditions, or the provider suspects poor patient compliance. In the outpatient setting, treatment with fluoroquinolones like ciprofloxacin and levofloxacin for 7 days is considered first-line therapy. If fluoroquinolone resistance is greater than 10% in the residing community, it is recommended to administer a 1-gram dose of IV ceftriaxone prior to fluoroquinolone administration. Bactrim is considered second-line therapy. Supportive and symptomatic care should also be initiated. It is also recommended that the provider reevaluate the patient in 2 days for improvement. First-line inpatient treatment for acute pyelonephritis includes a fluoroquinolone like ciprofloxacin or levofloxacin. Other alternatives can include ampicillin sulbactam, piperacillin tazobactam, ceftriaxone, meropenem, or ertapenem. It is important that the provider switch to PO antibiotics after the patient has been asymptomatic with a minimum of 2 days of IV antibiotics. Prevention and patient education is important to address when discussing acute pyelonephritis. For acute pyelonephritis, it is imperative that the patient take the entire course of antibiotics to eradicate the infection. Also, it decreases antimicrobial resistance. It's also important to encourage your patients to maintain hydration. For prevention of acute pyelonephritis, antimicrobial prophylaxis is an option for some individuals, and some researchers find this prophylaxis beneficial. Postcoital prophylaxis, continuous prophylaxis, and intermittent self-diagnosis and self-treatment have all been demonstrated to be highly effective at preventing reoccurrence of acute pyelonephritis. Antimicrobial prophylaxis treatment is patient-dependent, but it is commonly considered for women who have 2 or more symptomatic urinary tract infections within a 6-month period. Here are a few of my references that I used to make this slideshow. I thank you for listening to this presentation and hope you learned a lot about acute pyelonephritis. Thank you so much.